Furthermore, 60 of these 105 cases actually changed in score to below the cutoff. In other words, their final score was less than 11. Now, bearing in mind that the average score at intake was 23, some of those scores being, of course, a lot higher than 23, to think that 60 of these 105 were below cutoff post-treatment is very high indeed. In fact, it represents what is known in the language as a moving to recovery rate of 56%. Now, it's worth bearing in mind that the improving access to psychological therapies target has been revised downwards from originally 50% to now 40%, and this is for general anxiety and depression using GAD-7 and PHQ-9 measures. These are measures of anxiety and depression. And of course, obviously, the sort of clients who are reaching out for treatment from PTSD resolution are self-referred, highly distressed clients, often suffering from psychological traumas that have probably been going on for many, many years, and indeed in some cases decades. Therefore, they are often representative of a more chronic sort of sample of clients, rather than the cases that might be referred for sort of less severe anxiety and depression as is seen in primary care. Considering the effective treatment, looking at the lens through the impact of events extended scale, well, 131 cases had a valid pre-treatment score, and 122 of these 131 had a valid post-treatment score, which again is very high level of data capture of 93%. It's inevitable that in some cases there will be missing data for a whole variety of reasons, clients not proceeding in treatment, or on some day that the second measure hasn't been administered or whatever, but getting 93% data capture is very, very good indeed. And again, one can be confident in one's results when you get such high level of data capture. Now, for those 122 cases, the pre-treatment average score was 54, which is very, very high level of distress, and the post-treatment average score was 24. This is a very large movement in the scores. 79 of those 122 cases were above 50 pre-treatment. So if we just think of the cases that were above 50, after treatment, 66 of those 79, that's 83%, were below 50 post-treatment. And in fact, 59 of those 79, 75% of the cases had improved by 20 points or more. In other words, their scores had reduced. For example, if they had a starting score of 60, their finishing score will have been at least 40 or under 40. So 20 points of improvement. Now, in a way, even though you don't have reliable change indicators on the impact of events extended scale, remember on the core 10 we had 83% reliable change. So a 20-point improvement here at 75% of the cohort is somewhat similar. Okay, well, you can ask yourself, well, does it work? Well, certainly this evidence that we've got here based on these 150 or so cases would certainly be very indicative of the fact that this treatment certainly appears to have an effect. But of course, you have to remember we're in the context of NICE guidelines in the UK, and the fact is that the highest level of evidence for NICE guidelines is randomized trials or meta-analysis of randomized trials. That's not to say, of course, that, as you can see, there's those lower levels of evidence as well, going right down to C and GPP at the bottom there, good general practice recommendations based on clinical experience, which, of course, this type of evidence we've got here certainly reaches at the level of GPP or C. However, the critics will inevitably talk about this type of evaluation we've got here as not meeting the criteria for the highest level of evidence, which indeed is true, whatever this remains to be the case. NICE guidelines, after all, has this evidence hierarchy. The RCT is at the top of the hierarchy, or meta-analysis of RCTs. And out of that, we know that the treatment guidelines recommend trauma-focused cognitive behavioral therapy and eye movement desensitization and reprocessing. But of course, when you think about what trauma-focused treatment is, well, it's an umbrella of treatments, of a whole range of different treatments. And often some of these treatments are really quite different from each other. However, the common focus is that the patient's traumatic memories of the traumatic event and the personal meaning of the trauma dominate the focus of the treatment. And bear in mind that the research findings within NICE guidelines suggest that there's no difference at all between outcomes from any of these trauma-focused treatments. And in fact, what's interesting is if you look at, for example, one of the randomized trials that informs the guidelines based on the work of Duffy and colleagues in Northern Ireland at the Omagh bombings, victims of the Omagh bombings, the random allocation in this study, it was a randomized trial, but the randomized trial aspect was simply to waitlist control. So clients accessed the service and they were randomly allocated either to immediate treatment or to wait 12 weeks before having the same treatment delivered. Those clients who were in the control arm and were waiting for treatment, when they were assessed again after 12 weeks, were found to be no different. Therefore, there was no comparator, if you like, because there was no difference in terms, there'd been no change in their scores. So the results from that study were purely based on the findings of the treatment arm, in fact. And of course, their findings are of a magnitude that are certainly no greater at all than the findings within the PTSD resolution data, and were on much smaller sample sizes as well. In the total cohort was 58, whereas we've been looking here at active treatment on over 130 cases. Now, at the presentation I did at your conference 2 years ago, I was talking about Professor Gordon Turnbull, talking about the new frontier in the treatment of psychological trauma back then, 2 years ago. And what he pointed out was that a treatment that works on soothing the autonomic nervous system and works on the right hemisphere is likely to be a good idea. And I think it's safe to say that treatment through PTSD resolution is indeed a treatment that works on soothing the autonomic nervous system and does work on the right hemisphere, and so is likely to be a very good idea. And in fact, of course, one of the great strengths of working with the approach taken by PTSD resolution using the rewind treatment, which is the standard treatment deployed by human givens therapists for the treatment of psychological trauma, there are distinct advantages. Two, I think, would be worth pointing out. One is that the client doesn't have to narrate the details of the trauma, which would be typical of trauma-focused cognitive behavioral therapy in that traditional sense, where often recordings are made with the replay over and over again of the trauma and the articulation of the trauma. And secondly, the detail of the trauma itself needn't be narrated at all, in fact, and the therapist may actually be unaware of much of the content of the trauma. It's not actually necessary, and this of course helps prevent both the re-traumatization of the client and the vicarious traumatization of the therapist. So it certainly would appear from these results that have been presented to me that treatment through PTSD resolution for the relief of psychological distress as a result of psychological trauma within veterans would seem to be an excellent idea indeed. So I hope you've enjoyed this presentation. Thank you for your time.